Hello, and so if you just watched my last video on primary versus secondary hypogonadism, that will give you a good basis for understanding this case a little bit. So I want to talk to you about this case that I have of a patient who started to see me, this was probably 8 years ago or so, with some issues with both libido, sexual dysfunction, and just general motivation and confidence. So when he came to see me, he just kind of had these generalized symptoms, but his biggest concern was that his libido was not what it had been. He definitely was experiencing some degree of sexual dysfunction, not terrible, but was noticing it. He was in his late 30s at the time. And, of course, the things that I always do as a reminder is we run basic blood work, CBCs, metabolic panels, but also micronutrients like iron and B12 and vitamin D. But whenever I hear about these combined issues of low motivation, sexual dysfunction, some libido issues, maybe even motivation or brain fog, then it does make me think, okay, this is a great person to look at their hormones. Luckily with men, again, we can test hormones at pretty much any time. Now, I'm going to tell you the best time to actually test men and their hormones is early in the morning. That we have to be, at the beck and call of whenever the lab can open. But really, if we want to get optimal levels or at least higher levels as early as possible. And one of the things I've said in my previous videos is there was a study that was done that actually found that men release the highest levels of testosterone early in the morning, maybe 2 to 4 in the morning. So we're not going to get into a lab at that time, but we do know that we want to test it earlier in the morning if we can. If the lab opens at 7, yes, 7, 8, 9 a.m. probably as the latest. We want to look at testosterone. We want to look at estrogens. We want to look at DHEA. We want to look at thyroid, right? We want to do a very comprehensive hormone panel to understand what's happening. Now, this patient in particular had some other interesting symptoms. He had some gynecomastia. Gynecomastia means he was developing a little bit more tissue on his breast. He also did not put this in his intake, but he had issues with fertility. And in fact, he and his wife had not been able to get pregnant through natural means, and they actually contacted and received sperm from a sperm donor. So that was not part of his intake and only came out during the course of talking to him. Now, if you remember what I said on LH, if anybody remembers LH, luteinizing hormone, that is a hormone inside our pituitary gland, right? And LH can stimulate testosterone production, but also it helps in the stimulation and production of sperm, okay? So he had some infertility issues, and he was now having some libido issues. So besides testing the hormones, I also decided to test his luteinizing hormone. What was happening with his LH, and was his LH stimulating testosterone production? So in the process of doing this, what I found was that his LH actually was normal. His testes though, his testosterone was very low. So when I say very low, in my book, very low means under about 250. Low means still probably under about 450 or so, 400. And actually even suboptimal will probably be somewhere between 450 and 500. Over 500, I'm not really that concerned, especially if the free testosterone looks adequate. So when we tested it, low testosterone, frank low, under 250, LH was normal, if not high. And there are all of these other kind of interesting things, the infertility piece. So ultimately, we started treating with, you guessed it, testosterone. And when we treated him initially with topical testosterone, we had to apply it in a very interesting way, which I won't get into now because the patient had kids, and we do not want to use topical testosterone in any way, in any form, when a person has children at home, especially young children, especially female children. But there are ways, if a person is adamant on using topical, as this patient was, to utilize it, okay? When we started treating him, within a couple weeks of treatment, he already started to feel better. biggest thing he started to feel right away was increase in libido and motivation, right? Suddenly his confidence went up. He was a very active person involved in a lot of different sports, and suddenly he was able to participate in those sports, felt great about it, and was actually feeling like his libido and erectile function was actually a little better from this. In the long run, what I determined based on the infertility, or what I assumed, I guessed on, and we were not able to do genetics. The patient did not want to do genetics, but based on all of the symptoms and the understanding that this was primary hypogonadism, meaning that it was happening in the testes, is that this was likely a genetic issue. Again, there are a number of genes that are involved in the production, building of sperm and building of testosterone. So it's not easy to diagnose, but my guess after all this was this is likely a genetic issue. And likely as a primary hypogonadic issue, not a secondary, a primary hypogonadic issue, this patient, he will probably need testosterone for the rest of his life. Now, it's his choice whether he would like to stay on it or not. He does produce some testosterone, but it is quite low. And when he has come off of it, as he's done on 1 or 2 occasions, he notices a significant drop in all of those symptoms we talked about: his energy, his motivation, his libido. And so I always tell patients, it's up to you. How long do I have to stay on this? Really, it's up to you. Most of what we're doing is quality of life stuff. Now, is there some health benefit to it? 100%. There absolutely is. Muscle wasting, or muscle building, I should say, bone building. These are all helpful. Dementia, depression. We know that testosterone can help with each of these, and with lower levels as we age, these things become more prevalent. Anyhow, hope that helps. Thanks.